Hello, everyone. Welcome. I still see folks trickling in. We have a lot of information for you all, so we're going to just get started. Yeah, welcome. Good morning. We're so excited to have you join us today for the state of sexual and reproductive health for youth in foster care, delving deeper into California's landmark data report. Like I said, we have a ton of really important information for you all. So we're going to go ahead and share our slide deck in the chat along with the data report itself. So you all have it in case you would like to follow along in the slide deck or take a look at the report itself later on. So my name is Cindy Cruz. My pronouns are she and her, and I'll be your host or your MC for today. Joining us today as presenters will also be Rebecca Gudeman, who's our Senior Director of Health at the National Center for Youth Law, Alicia Walker, who's Associate Governmental Program Analyst at the California Department of Social Services, Catherine Elliott, who's a Research Data Specialist at the California Department of Social Services. Welcome, y'all, and thank you for joining us today. And we have a few panels lined up for today. Our amazing panelists will respond to some of the data that is going to be presented and also help give it some context. On our panel today are Alexis Obina, who's one of our RHEP Youth Advisory Board members. We have Elizabeth Anderson, also one of our Youth Advisory Board members, and Tamar Sebesta, also one of our RHEP Youth Advisory Board members. We have Erica Monasterio, who's our family nurse practitioner, and Onyema Obiekia, who's a policy director at Black Women for Wellness. So welcome you all. Thank you for being here. We're excited to have you as part of our panel. So I'm going to dive quickly into our agenda and what you can expect from our webinar today. I'm going to start by giving you all a quick introduction on RHEP and what we do. We'll dive into a little bit of background on AB 172. Then we'll dive into the report, learn about methodology and findings. We'll have some time for Q&A, and then we'll learn a little bit about what's next. For questions today, like I said, there's a ton of information. Please ask questions using the Q&A box, and those will go directly to the host and the panelists. Questions will be answered either live or via the chat. And if we're not able to answer your question today during the webinar, we're going to make sure to respond in a follow-up email. And so a quick note on language. So at RHEP, we believe that all people deserve comprehensive reproductive sexual health education and care. And we strive to use inclusive and people-first language in this presentation. However, there are times when we will need to use gendered language, such as the word women, or specific race ethnicity terminology, such as the term Hispanic, to conform with the data that was collected. And we're also will be condensing language to fit slides as necessary. So a little bit about RHEP, the Reproductive Health Equity Project for Foster Youth, we're also known as RHEP, is a collective impact campaign that brings together foster youth and the agencies that serve them to dismantle systemic barriers to sexual and reproductive health education and services access for youth in foster care. Our overall goal is to improve the healthy sexual development and bodily autonomy of youth in foster care. And here on this slide, you can see some of our leadership team member agencies. The National Center for Youth Law serves as the convener and facilitator of the RHEP Collaborative. So California policy has made slow but steady strides to improve the reproductive and sexual health of foster youth. Youth in foster care historically have faced disproportionately poor reproductive and sexual health outcomes. An important contributing factor was the lack of focus on the issue. So even as late as 2015, there was no state policy specifically addressing how to support the healthy sexual development of youth in care. But starting in 2015, the state legislature and Department of Social Services stepped in to address this gap through legislation, regulation, policy, training, and support guidance. Undergirding this state effort was a critical recognition and acknowledgement by the state child welfare agency that supporting the healthy sexual development of youth in care is part of the system's overarching obligation to support normalcy and the normal development of youth. Many of the obligations now in state policy stem from this overarching recognition, and RHEP began in 2016 and has since then been working in partnership to support this work. So in this slide, you'll be able to see some of the important changes along the way, including the issuance of California's plan to address unplanned pregnancy and foster care in 2016, the passage of Senate Bill 89 in 2017, and the passage of AB 172 in 2021. So AB 172, the Healthy Futures for Foster Youth Act, was passed in 2021, and it was sponsored by several members of the RHEP Collaborative, including the National Center for Youth Law, Black Women for Wellness, Children's Law Center, the Alliance for Children's Rights, and John Burton Advocates for Youth. And it was authored by Assemblymember Rubio. It required CDSS, or the California Department of Social Services, to develop an annual data report on the sexual and reproductive health outcomes of youth in California's foster care system. So the report has two main requirements. One is that it requires data on performance and outcomes, which includes trainings and programs, and outcomes includes reproductive and sexual health services that are received by youth in foster care. And it also requires that this data be disaggregated by key variables. The second requirement is for CDSS to collaborate with the Department of Healthcare Services, the Department of Public Health, and others in the development of the data, and also to consult with the Healthy Sexual Development Workgroup. So this report and data tracking is really important, and we're really excited about it. Before AB 172, there were very limited sources of information, and a few of those are listed here. Under federal law, the state does track and report data on transition age youth as part of the National Youth in Transition Database. It covers youth starting at age 17 through age 21. And this database tracks how many transition age youth who are formerly in foster, or were formerly in foster care are parents. It does not include any other indicators related to sexual or reproductive health. The California Child Welfare Indicators Project is a collaboration between UC Berkeley and CDSS, and it is a vitally important source of information on youth in foster care. It provides the public with access to critical outcome information on California's child welfare system. Most of the data, though not all, comes from child welfare records, and there is an indicator that tracks parenting youth in foster care, but no other indicators related to sexual or reproductive health. One of the most comprehensive resources for data on the sexual and reproductive health of youth in foster care is something called the Cal Youth Study. And so in that study, researchers from the University of Chicago partnered with CDSS to interview a sample set of youth in foster care at the ages of 17, 19, 21, and 23. And they asked them questions that included questions around pregnancy intention, sexually transmitted infections, and general healthcare access. But this was a time-limited study that took place between 2012 and 2022 that relied on public funding. So AB 172 is different in a few key ways, as you all can see. It is developed by a public agency. It covers a broader range of health indicators. It reflects data on youth as young as 10 years old, and it will be reported out annually, so we're able to track changes over time. And the health data, as you all will hear more about today, comes from Medi-Cal billing. So it doesn't rely on self-reports of youth or third-party reports by social workers or others. And because this is so new, It was really a huge effort to put this first report together. So we just want to congratulate CDSS and DHCS, who really worked from the ground to build this report up. And we want to take a moment to thank them for their incredible work. So we're really, again, excited about this report. So thank you all. All right, so let's go ahead and dive into the reports. Our first section, or well, this next section is going to focus on methodology and findings, and we're going to jump in there. The report has 3 different sections. So it's divided into training and education, programs, and reproductive health services. So I'm going to pass it on to Alicia, who's going to talk to us about training and education and programs. So Alicia, I'll pass it on to you.
Thank you, Cindy. Let's see. Okay, so in 2017, SB 89 implemented the requirement for child welfare workers, juvenile court judges, group home, and short-term residential therapeutic program administrators to complete the sexual and reproductive wellness for youth and foster care training. Currently, its training can be done in person in a classroom setting or through e-learning through the statewide California Child Welfare Training Learning Management System. Next slide, please. Before I go and jump through the results, I'd like to quickly go over the various systems and folks we obtained this data from. So for social workers, folks at the University of California, Berkeley, pulled the results from the California Social Work Education Center and California Child Welfare Training. And then during that time, we learned that LA County does not track their training through those systems. So we obtained LA County's completion results from LA Children and Family Services. For group home and short-term residential therapeutic program administrators, completion results are tracked and was provided from our internal CDSS partners in the examination and certification processing unit. And for judges, we reached out to representatives from the Judicial Council of California. And lastly, expectant parent payment and infant supplements were pulled from the statewide automated welfare system. Okay, and so for the results, let's see. We had 1,169 social workers who completed the training that was both in person and online. We had 222 newly appointed judges complete the training, 1,145 active group home and short-term residential therapeutic program administrators who completed the training. And for LA, there were 2,999 social workers and supervising children social workers. Next slide. So yeah, for data limitations and some challenges that occurred, as mentioned earlier, there were many systems we had to use in order to collect this data. So it was a lot of collaboration efforts. And another limitation was that we were not able to obtain a statewide total for caseworkers. I mean, not a big limitation, but it was a challenge. Next slide, please. Okay, so now we're going to go into EPP. As indicated on this slide, the EPP was implemented in January of 2022, not 2021, which provides a one-time payment of $2,700 directly to an expecting youth 3 months prior to the due date. So data from CalSOLS reported that from January to September of 2022, 83 foster youth received the EPP. We were unsure if these numbers are so low due to it being a newly implemented program or because automation has not yet occurred and counties currently had to create their own system to identify and enroll in expecting youth. Next slide, please. Okay, so the infant supplement begins the month that the infant is born and continues as long as the non-dependent infant continues to reside with the minor or non-minor dependent parent in an eligible placement. And CalSOS reported that 1,151 youth received the infant supplement. Next slide. Okay, and for this report, CDSS could not obtain the comprehensive sexual education completion rates for foster youth due to limited documentation in the Child Welfare Services and Case Management System. However, these rates will be included in the next report. So that was one item missing for the training portion, the performance section of the report. Next slide. And that's it.
Thank you, Alicia, for all of that information. So we're going to go ahead and jump into our first panel, or our first of three for the day. And this one will be with our Youth Advisory Board members. So this will be for Alexis, Tamar, and Elizabeth. So we just saw data on the number of social workers, judges, and STRTP staff that were trained on how to support the healthy sexual development of foster youth. Can you all tell us why you think it's important for folks to get, or specifically, we talked about social workers, judges, and STRTP staff to get training on how to support youth around their sexual and reproductive health? Alexis, let's go ahead and start with you. What are your thoughts?
Yeah, thank you, Cindy. I first want to say hello to everyone. I'm excited to be in community with you all. Can you hear me?
We can hear
Okay.
you. It's a little low.
Okay, let me just one. So sorry, everyone.
That's better, Alexis. I can hear you better.
Okay, cool. Hey, everyone. It's Alexis, and unfortunately, I'm in DC. So when I look at my notes, I think my camera may turn off. So just a disclaimer. But I do want to say that sexual reproductive health is a right to people in California and now some other states. And so in California, so STI tests and reproductive health screenings are free for folks, and many people don't even know it. And so I believe that doctors, social workers, people who just have any touch on the child welfare system have a moral and ethical right to tell these patients and advertise these services. And I just want to add that these are programs that are already being funded. So it's not like, we need to hide them or it's in any like ration or anything. These are open services. There's plenty to go around. And so as I was finishing social work school, we learned about the social work code of ethics. And I believe no matter the profession, it's always ethically right to want the best for the people that we serve. And so it's finally time to start putting words into practice. And I'll pass it to Elizabeth.
Thank you, Alexis. Yeah, Elizabeth, what are your thoughts?
Yeah, thank you. I think that everyone has different sexual and reproductive health care needs, and people aren't all the same. We're not all monoliths. And so people deserve to access the care that they specifically need. So with training, our social workers are supposed to be the people who follow us around and who are able to know our needs the best and help us and advocate for us. So if they have the proper training, that will be able to support them in helping youth obtain the care that they actually need and deserve. Thank you.
Thank you, Elizabeth. And Tamar, we'll pass it on to you. Anything you want to add?
Thank you both for sharing. For me, I think of how it's really important to have that trauma-informed education because as foster youth, we have a lot of trauma when it comes to family separation. And without being properly trained, you might not know as a social worker how to handle someone who's been through trauma. And that lasting impact can change a youth's life if you are able to have the care and background needed, to, I think, do your job. And it's really difficult not really knowing what this impact is, right now. And I really hope that more people get trained. And for me, like, it was a really traumatic experience, and there can be a lot of anger, there can be aggression. So I think as a social worker, you need to know how to handle those situations so the youth can have the best care.
Thanks, Tamar. Thank you all so much for sharing your thoughts. So we're going to go ahead and keep moving and learn a little bit more about the reproductive health services that were received by youth. I'm going to pass it on to Catherine to tell us a little bit more about how the data was developed.
Hi, everyone. So happy to be here presenting this first ever data on reproductive health services for foster youth for the state of California. So a little bit about how we went about this. We had to match our data from the CDSS, our data on foster youth, with the Medi-Cal claims data collected by the Department of Healthcare Services. So once we did the match of the youth, we were able to pull in all the services that they received for the 2020 year. So this report is specific to 2020. We were able to compare services received by foster youth compared to services received by youth not in foster care. And to look at the kinds of services received, we used what's called the core set measures. And these are measures developed by the Center for Medicaid Services at the federal level. So all states are required to produce these measures. And they're basically indicators of how well states are providing health services, and in this case, reproductive health services. Next slide. So the specific core set measures that we use for this report were looking at prenatal care, postpartum care, contraception. We also collected data on the number of live births weighing less than 2,500 grams, so low birth weight babies born, well care visits, chlamydia screening, and low risk cesarean delivery. Next slide. So just a quick caution about as we go through the results, you're going to see groups with more or less in terms of the services they received. When there's a difference between groups, sometimes it's just a chance. So it's chance fluctuation. Maybe this year it's a little bit more, maybe this year is a little bit less. But sometimes it does reflect a true systemic difference that we would see year after year, or if we did the study again, we would see it again. So in order to determine which one of those is a true difference, we use tests of statistical significance. And as we go through the results, you'll be able to see which ones of those differences are statistically significant. And then also another note, sometimes when the sample size is really low, so for example, with low birth weight babies, that's a very small group. So there are some small differences, but it's hard to detect statistical significance in those groups. So that's just another note of caution as you look at the results. Okay, so handing it off for, I think Rebecca's going to present our actual findings on reproductive health services.
Thank you, Catherine. Rebecca, we'll pass it on to you.
Yeah, great. And Catherine, please jump in if you need to add anything. I'm just sort of helping taking a turn sharing our data. So if you could go to our first slide, Cindy. So this slide shows us the percentage of youth aged 10 to 20 who received timely prenatal care. Timely prenatal care means initiation in the first trimester of pregnancy or within 42 days of Medicaid enrollment. Initiation of prenatal care during that first trimester facilitates comprehensive assessment of a pregnant person's health history, their pregnancy risk, and their health knowledge. And it also allows for early screening and referral for specialized care to prevent any kind of pregnancy complications that may result from any pre-existing health conditions. And so what we see here is that only 55% of youth in foster care aged 10 to 20 received timely prenatal care in 2020, as compared to 65% of same age youth not in foster care. And that was a statistically significant difference. Notably, both groups of youth were far less likely to initiate prenatal care in a timely way as compared to all pregnant people. So the bottom bar shows the national average for all people in Medicaid managed care, and that number is 84%. Next slide, please. This slide shows us the same data disaggregated by race and ethnicity as those identifiers are marked in the DSS or DHCS data sets. We see that in almost all cases, the rates of timely prenatal care were lower for youth in foster care. Although the differences between foster care and non-foster care groups were only statistically significant for those who identified as either Hispanic or white, and you'll see that with the little orange asterisk. For unknown and other, it's important to remember, as Catherine just said, our sample sizes are likely pretty low, so we may see more variation in numbers, and but that was not deemed to be statistically significant. Next slide, please. This slide shows us the percentage of youth aged 10 to 20 who receive timely postpartum care. Timely postpartum care means receiving care between 7 and 84 days after delivery. Postpartum visits provide an opportunity to assess a person's physical recovery from pregnancy and childbirth, address any chronic health conditions such as diabetes, critically to assess mental health status, including screening for postpartum depression, and address any family planning needs. And what the data shows is that only 53% of youth in foster care aged 10 to 20 receive timely postpartum care, as compared to 67% of same age youth not in foster care. And again, this was a statistically significant difference. And again, notably, both groups of youth were far less likely to initiate postpartum care in a timely way as compared to all pregnant people. So the bottom bar again shows us the national average for people on Medicaid managed care accessing postpartum in a timely way, and that was 75%. Next slide, please. So this slide shows us the same data disaggregated by race and ethnicity as those are marked in the data sets. We see youth who identify as Black or African American, both in and out of foster care, were accessing postpartum care at lower rates, with only 46% of Black foster youth getting timely postpartum care. And this was over 7 percentage points lower than the foster care average. And it was actually over 20 percentage points lower than the non-foster youth average of 67%. Next slide, please. So this shows us the low birth weight inference. It's a measure of deliveries to infants that weigh less than 2,500 grams at birth. It's a really important indicator, as it's a signal of how a population is doing in terms of their health. Infants born at low birth weight experience severe health and developmental difficulties that can impose substantial costs. For example, the risk of death within 1 year of birth is 1 in 5, so 20% for low birth weight infants. And the expected cost of delivery and initial care for a baby weighing 1,000 grams at birth can exceed hundreds of thousands of dollars. And at the population level, according to the World Health Organization, the proportion of babies with a low birth weight is a key indicator of that there is a multifaceted public health problem that could indicate various things from long-term maternal malnutrition to ill health, hard work, or just general poor health. Here we see that foster youth were more likely to give birth to a low birth weight infant as compared to other youth on Medi-Cal, but this was not statistically significant. As a point of comparison, we've included data from Medicaid for a few other states, and this is data that is not specifically for youth, it's for all people who gave birth. But again, as Catherine noted up front, because of the small numbers that we're talking about here, it may be more difficult to find statistical significance. But let's look at the next slide. So here we see two things. First, we see that Black youth, both in and out of foster care, had similar rates of low birth weight infants, both just over 12%. Second, we see that youth who identify as Black had much higher rates of low birth weight infants than youth overall. So comparing the foster care overall rate to the either of the two rates for youth who identify as Black. Tests of significance were not conducted for this finding, but it does mirror what we see in the general population. And that's really important because remember, this means their infants have a 20% chance of dying in their first year. And it's a really important indicator of general health of a population. Given the correlation between birth weight and multiple adverse health outcomes, understanding and addressing the causes of low birth weight deliveries, regardless of foster care status, is also a critical priority. Next slide, please. So we're going to take a break now and pass it to our panel and Cindy. But before we do, we just wanted to leave you with this important thought. The poor health outcomes referenced earlier are not primarily about the individual. A person's health is impacted positively and negatively by a number of factors that are often referred to as the social determinants of health. Those social determinants are the conditions in the environment where people born, live, learn, work, play, and age that affect our health functioning. Examples of social determinants of health can include housing conditions, poverty, educational opportunities, and critically, racism and discrimination. And it's pretty clear that youth in foster care are more likely to face social determinants that can negatively impact their health opportunities, often in multiple fronts. So with that, I will pass it back to Cindy and our panel.
Thank you, Rebecca, for all that information. And again, thank you, Catherine, also for that information. We have a lot to digest. So as Rebecca mentioned, we're going to move on to our second panel, which includes two of our Youth Advisory Board members, Alexis and Tamar, and Onyema, one of our partners from Black Women for Wellness. So our first question is going to be for our Youth Advisory Board members. As I mentioned, there is a lot that we just learned. One item was the fact that foster youth are not starting prenatal care in a timely way as compared to non-foster youth who are pregnant. What is your reaction to this, and what do you think may be happening here? Tamar, let's start with you.
Thank you, Cindy. For me, I had my son when I was 15, right after I had exited care. And because of this, when I was trying to receive services for Medi-Cal for me and my son, there was no one to help support me. So it was really just me winging it at a really young age. I remember being in the office and they were just completely unhelpful. I had no idea how to find a doctor that I could even choose a provider. I didn't know how to get my son on the services. So that really impacted my entire prenatal experience. Just, I never had a doctor. It was whoever was available. There was no consistency. And because of that, my file was consistently mismanaged. I had a lot of health problems. Not having my mom's medical history because I was in foster care, they didn't know that I was at risk for a lot of different ailments with my pregnancy, and even the postpartum care as well. You know, a lot of people just think about when the baby's born, but they don't think about the mom. And being a high risk pregnancy so young and being a former foster youth, I was high risk, not only emotionally and physically, but no one was there to look at my chart and say, hey, like she might need, you know, services for postpartum depression. She might need support in finding resources, you know, to raise her baby. There was none of that. And it felt like I was really left behind, and just a lot of pushing, you know, to like not get pregnant again, and not really managing the fact that I was pregnant and had a kid, you know. And there's just really, it was really traumatic. But I'm really hopeful that things will change and it'll be a lot better in the future.
Thank you, Tamar. Alexis, what are your thoughts?
Yeah, thank you so much, Samar. You guys can hear me now, right? I had to take my headphones off. So I
Yeah,
just
we
think that
can.
there's so many difficulties of navigating the Medi-Cal system. And so approvals, being able to advocate for yourself, and just the red tape in general. And so Medi-Cal does not really inform us of services that we can be provided. And it usually falls on the patient or the doctor to figure out what qualifies and what doesn't. And so also some providers make people jump through hoops in order to be able to access doula services. And we all know that those are very important. So while other providers make it accessible, and even some providers target high need areas and zip codes with needs for these services. And so I'm not a sponsor, but I just want to shout out like LA Care because when I switched from the Medi-Cal system to LA Care, like they really made me feel like I was a part of my health decisions and that I was in control of my needs instead of them telling me what I need, which I knew I didn't need. So thanks. I'll pass it on.
Thank you, Alexis. Thank you both for your thoughts. Onyema, I'm gonna pass on the next question to you. So one of the things that we also learned was that youth who identify as Black and African American may have higher rates of low birth weight infants. Can you tell us your thoughts on that?
Yeah, thank you, Cindy. Thank you to everyone on here for the beautiful presentations, your thoughts and your insights. I'm deeply grateful to hear from the youth advisory board leaders and the youth around their lived experiences when it comes to navigating Medi-Cal, the healthcare system, because clearly we're able to hear gain insights on the barriers that the healthcare systems sort of implement or that are just existent within the healthcare system that work to prevent folks from, especially young folks, from accessing the care they need. So, I'm grateful to hear the lived experiences of folks. But to your question, Cindy, like it's devastating. My thoughts on this is that it's devastating, right? But it's not surprising. We know this to be the case for Black people capable of giving birth generally, foster youth or not. So I'm not entirely surprised that this is the case. Nevertheless, it is devastating because we know that birth weight is an indicator of whether an infant will make it to their first birthday, as Rebecca earlier stated. So we can't deny, like, at least in this context, the impact of sort of racism. That's what keeps coming up for me. Interpersonal, structural, systemic, all those, all that sort of works to impact the birthing outcomes of Black birthing people. And so for me, it's clear that this is mirrored in the birth outcomes for foster youth. And that's devastating considering the additional burdens, right, that foster youth now have to navigate and deal with by virtue of being foster youth. With those stats, what's interesting to me and what comes up for me is the relationship among the three data points. We have Black foster youth's likelihood to obtain prenatal care. Then we have the rate of low birth weight babies that Black foster youth give birth to. And then we have the receipt of timely postpartum care. Between prenatal care and postpartum care, I want to know what happened, right? And we heard a little bit about this already, right? For me, it'd be really interesting to look into that because here we have youth who are doing what they're supposed to do in the beginning, right? Yet they are more likely to have this adverse outcome that increases the risk of their infant not making it to the first year of their birthday. And then the likelihood of seeking postpartum care decreases significantly. I'm really curious about what happened in this period of time. In what ways did the system not work for our youth who are clearly trying? Why are they not returning for care? What barriers are erected, right? Is it our interactions with providers? We've just heard that it's, there's no consistency with regard to providers. Medical records aren't adequately kept. What about certain biases, implicit biases, right, with regard to Black youth, and then Black foster youth at that? The impacts of stress from sustained interpersonal racism have been studied, and we're learning that chronic exposure to interpersonal racism has an impact on birth outcomes for Black birthing people. This includes heightened low birth weight babies. So, especially, as birthing people age, to see that Black foster youth experience disproportionately higher rates of low birth weight babies, to me, requires deep inquiry, because then that goes against this whole, or it sort of interrupts this idea that the older you get and the longer you sustain chronic exposure to interpersonal racism, that's when the adverse outcomes happen. Here we have youth that are experiencing poor, birth outcomes in terms of low birth weight when you're Black. So I really am interested in interrogating that to see what that means. What is the cause of that? Because they are trying. They're doing the thing that we're supposed to do. Go and access prenatal care. All right. Then what, right? They're seemingly too young to be victim of the weathering effect. So what impact do their intersecting oppressions, being Black, birthing people, youth in foster care, among others, have on their health outcomes? I think that piece is really interesting and still needs to be sort of interrogated a bit more and delved into. But overall, it's devastating. But I appreciate the fact that we are collecting this data and we know where to investigate, and it leads us as to like how to approach, what questions to ask, I think.
Thank you, Onyema, for raising up those really, really important points. And I know you talked a little bit about, what's kind of happening between accessing prenatal care and then postpartum care, also giving birth. And Tamar, you touched on this a little bit about your experience of accessing postpartum care. So I'm going to give our last question to you, Tamar. You also mentioned that, once a baby's born, there's a lot of focus on the infant and making sure the infant is okay. And you also raised, like I said, postpartum care is really important and sometimes forgotten. We looked at, some of those numbers around accessing prenatal care, as Onyema mentioned. Can you tell us a little bit about what you think, why you think youth may not be getting timely postpartum care while they're in foster care?
Yeah, Cindy, I think it's definitely just because of the issue of not having someone to help us find the information. We don't really know it exists anyways, and how to receive it. And I think that it could be so helpful, to have like a set person in place where their job is to help high risk youth find that care and find instructions on how to access it, because we don't really have anyone to help us. And I think it's difficult for anyone, to access the medical system nowadays, especially if there's no one really to guide you. The point blank is I think people just don't know. And that was my experience. I just didn't know that it was a thing. And, that lasting impact is why we're seeing the negative statistics. And it's why a lot of issues keep happening, because it's kind of like a cycle, and I think it also makes it hard for us in the terms of like pregnancy, like for our children as well. Like they're then not going to receive care as well. So it kind of trickles down and is very systemic. So I hope that answers your question, but yeah.
Thank you, Tamar, for sharing your experiences with us. So now we're going to jump back into some of our data. and talk a little bit about the findings that we found of findings around preventative care. And Rebecca, I'm gonna pass it on to you.
Thanks again, Cindy. All right, if we can go to our next slide. So this slide shows us a percentage of youth age 15 to 20 at risk for unintended pregnancy who were provided what is considered either a most or moderately effective method of contraception. Most or moderately effective method of contraception means birth control implants, IUDs, pills, patch, ring, or diaphragm. The goal of this measure is to provide an indicator to assess the provision of contraceptive methods and see where there's room for improvement. Increasing access to effective forms of contraception is a great strategy to reduce unintended pregnancy. And we do know that youth in foster care face higher rates of unintended pregnancy, so this is important. Here we see that over 21% of youth in foster care age 15 to 20 were provided contraceptives that were considered most or moderately effective, as compared to just under 12% of youth on Medi-Cal not in foster care in the year 2020. In other words, foster youth received contraceptives at almost double the rate of other youth in 2020. Next slide, please. This slide shows us the percentage of youth aged 16 to 20 identified as sexually active who were provided a chlamydia screening. Chlamydia is the most commonly reported sexually transmitted infection and is easy to cure when it's detected. However, most people have no symptoms and are not aware they're infected. And if it's left untreated, chlamydia can affect a person's ability to have children in the future. Recommended well care for young adults who are sexually active includes annual screening for chlamydia. Here we see that 67% of youth in foster care who were identified as sexually active were provided a chlamydia screen compared to 55% of youth not in care. This held true across all racial and ethnic groups. Notably, disaggregated data does show some opportunities to do much better for youth not in care. For example, only 45% of youth who identified as Native American and who were on Medi-Cal and who were identified as sexually active were provided a chlamydia screen. So you can see more about that data in the report itself, which we've included in the link. Next slide, please. This slide shows us the percentage of youth aged 10 to 20 who received a well care visit in 2020. The American Academy of Pediatrics recommends annual well care visits during adolescence to promote healthy behavior, prevent risky ones, and detect conditions that can interfere with a teen's physical, social, and emotional development. And it is part of the standard package of care that Medi-Cal does provide to provide annual opportunities for annual well care visits. So what we see here is over 62% of youth in foster care aged 10 to 20 received their annual well care visit, compared to just under 47% of other youth in Medi-Cal. And this held true across all racial and ethnic groups. And with that, I will pass it back to Cindy.
Thank you, Rebecca. Okay, so we are going to jump into our last panel for today, which will include all of our panelists. Erica, we're going to start with you. So the information that Rebecca just shared with us, in that we see pretty great rates of well care visits for youth in foster care. Is the well care visit an opportunity to talk about contraceptions, STIs, and other preventative care, in your opinion?
Absolutely. First, I just want to note that adolescents and young adults are actually the population group least likely to receive preventative care. So this data for foster youth looks really good in terms of being propelled into a well visit. Now, that doesn't say anything about the quality of the well visit, but this is something that's monitored, something that's encouraged, something that foster parents and group homes are expected to facilitate, so they are getting into care. The concern is what's happening in those well visits. So, internationally, universally, the United Nations Convention on the Rights of the Child specifically identifies the right to control one's health and body, including sexual and reproductive freedom, to make responsible choices through access to a range of facilities, goods, services, and conditions that provide equality of opportunity for every child. So this is not just something that we're looking at in foster care. This is something for all youth all over the world. As Rebecca mentioned, the American Academy of Pediatrics mandates pediatricians to provide well visits, and they advise pediatricians to take a targeted, developmentally appropriate sexual history, assess for STIs, pregnancy risk, provide counseling, etc. So most youth in foster care are probably receiving care from someone trained in pediatrics or family practice, and the professional organizations for these physicians encourage them to provide sexual and reproductive health care. And then the Society for Adolescent Medicine and Health, which is really sort of who advocates in the US and internationally for adolescent health and young adult health, makes very clear recommendations about access to information, education, and care. So adolescents should have universal access to comprehensive sexual and reproductive health care that's developmentally appropriate, that's culturally sensitive, that's evidence-based, and most importantly, and often interrupted, is confidential. Although youth in foster care actually have additional confidentiality protections, many adults interacting with youth in foster care are unaware of their confidentiality protections. And this can create a real barrier to sharing information and getting the care that they need. In California, sexual health education is often in the domain of the schools, but for youth in care, they may not be able to access it because of placement or health or school instability. So SB 89 attempts to address that, but we don't really know what training case managers and social workers are getting in terms of their not informational training, but interactional training. How are they conveying information? How are they working with youth? And time and trust really impact on these conversations. So is it developmentally appropriate? Are they comfortable conveying the information? Are young people in a space where they can really engage with their case manager or social worker about very personal, private issues, especially when there's concerns about confidentiality or concerns that this might impact their placement or their stability? And we know also that healthcare providers just don't always have the appropriate knowledge or skills, and most importantly, time to really do this work right, particularly with populations who have significant trauma in their background. It takes time, it takes sensitivity, it takes awareness, it takes a trauma-informed system, not just that one person you're sitting with, but that whole system that's going to support the young person and provide services where they're really the captain of their own ship, they're in charge, they are respected, and they are supported. So all of these things kind of get in the way. Confidentiality, as I mentioned, is really key for any of these interactions, and when it's not assured or it's assured but not really respected, that can provide not only barriers for that young person at that moment, but for that young person over time, and for all of their friends and associates, because all you need is one person having a bad experience for the voice to carry to everyone they know that this is not a place to go. You can't trust these folks. They told X, Y, and Z to A, B, and C, and there goes your opportunities for education. The other thing I would mention is that just because something's prescribed doesn't mean that there's follow-through, doesn't mean it was the right choice for the young person. For example, our most effective methods, which are our long-acting reversible contraception, are provider managed, not patient managed. And the implementation of those methods can be coercive. It is definitely not always on a model of shared decision-making. And young people often feel that they were pushed or didn't have a choice. And when they have the opportunity, they will get rid of that method. because they don't like it, because they didn't understand the side effects, or just because they felt completely disempowered around getting the method in the first place. So in summary, it's a great opportunity, but I'm afraid it's often a missed opportunity. It's really just an opening. It's the possibility for getting information and services, but it's no guarantee. And particularly for youth with histories of trauma, which kind of by definition is the universe we're talking about here, you just can't assume that in the annual WellCare visit, all these things are being covered. There are many, many mandated issues to address. And it takes more time and more visits and time to build trust and rapport. And if you get one well visit a year in your new placement with a different person and you never see them again, you're not going to have the relationship that really supports that.
Thank you, Erica. Yes, thank you for all of that you just shared. I have one more question for you. Looking at the contraceptive data that we saw. So for young people between the ages, of 15 to 20 years old, we saw that youth in foster care access contraceptive services at about 21%. And for youth not in foster care, that rate was 11%. We know that, you mentioned coercion and things like that. When it came to contraceptive use, we know that the rate is not supposed to be 100%, but how do we know what we should be striving for here, taking into consideration everything you just mentioned, right? Like a shared decision-making model and all of that.
So for sure, we need more data, we need more consistent data, and we need more population data on the foster youth population. Because what we have is we try to kind of lay over the data we have on the foster youth population and make sense of it. So you have the National Survey of Family Growth, which is longitudinal, so it's over time, looking at changes in behavior, which has one set of data that an estimated 45% of 15 to 19-year-old male and female youth in the US report having had at some time vaginal intercourse with an opposite sex partner. That doesn't address, was it volitional, was it forced, it's just, that's the question, that's the answer. And then in that data set, 2.5% of that same age group among young men saying that they've had oral or anal sex with another male, and 11% again of the same age group of young women reporting that they've had a sexual experience with, including oral sex with another female. So that's 15 to 19-year-olds in one data set. When you look at the youth risk behavior survey that the CDC does every 2 years, last data published is from 2019, actually, it has 27.4% of high school students report being sexually active in the last 3 months. So what's the definition of sexually active? We're not sure, and it's in the last 3 months. So you have this problem with data. You have different age groups, you have different developmentally appropriate behaviors. What we expect in 15-year-olds, or in 19-year-olds, we don't expect in 15-year-olds necessarily. There's different questions asked with different definitions of what is sexually active. But what we can say clearly is there are folks who could benefit from services that aren't getting them, because now you have a subset of foster youth who are making a choice to get pregnant and parent, but the majority of foster youth say that their pregnancy was not intentional. So they clearly are not either getting access to services or access to appropriate, culturally sensitive, trauma-informed services that they can actually access. Just because you walk in the door doesn't mean that you're getting what you need. So it's hard to say what we should be aiming for, but if we saw no unintended pregnancies, we'd be getting a lot closer to our goal.
Thank you, Erica, so much for that. Okay, I'm gonna pass the next questions over to our Youth Advisory Board, to Elizabeth and Alexis. I know in our YAB meetings we talk a lot about access to healthcare and experiences. Is there anything you all would like to share about experiences accessing or trying to access things like contraception or sexually transmitted infections? Elizabeth, we can start with you.
Yeah, thanks, Sydney. I just wanted to talk about how many inequities there are in terms of accessing care, especially for youth who identify as LGBTQ. And I know that RHEP has some data that shows that identifying this way is a barrier to healthcare. A lot of people in this community are scared that their provider might be discriminatory towards them and not give them care, and also especially out them when they're not ready to express their sexuality out to everyone. Like a lot of lesbian and bisexual women, for example, those who identify in that way, they might get pushed certain forms of birth control and contraceptives because they say they're sexually active, but what their providers are assuming that they need isn't always completely accurate. And so that's not what meets their needs, and they might have a hard time advocating for what they do need, especially with all the stigma associated with that sexuality. And similarly goes for people who identify as gay men. They might be afraid of speaking up for HIV testing due to social stigma, but they also might be over-tested if providers are thinking that their sexuality indicates that they must have HIV, so they might be over-tested, and all of this could be a really traumatizing experience, especially for foster youth who are also identifying as LGBTQ. So I know that this current report that we're talking about doesn't have a lot of data on that, but I just want to let everyone know, and I hope that this isn't a reflection that these youth are forgotten about, because they also need specialized support as well.
Thank you, Elizabeth, for sharing that. Alexis, any thoughts or anything you'd like to share?
Yeah, thank you so much, Elizabeth. I just want to add that instead of forcing any medication on anyone, it is the duty of doctors and staff to give all relevant information like side effects, if this was tested on people of color, um, any information that any normal person would want to know when taking these prescribed drugs. And so if a patients should feel empowered in their healthcare decisions, not like they are just another case to another system, like I added earlier. And the providers must also respect young people's autonomy, especially when they feel they know what is right for themselves.
Thank you, Alexis, for sharing that. Okay, Onyema, I'm going to pass the next question on to you. So the report includes data on LARCs, or long-acting reversible contraceptives, such as the IUD and the implant, and non-LARC contraception, such as the pill, the patch, or the ring. We didn't share this information in the webinar, but it is included in the report. What might be important for folks to understand about the differences between like the LARC methods, the non-LARC methods, and some of the information we're seeing there?
Thank you, Cindy. I think in terms of LARCs, and from the RJ perspective, I think, and sorry, I recognize it's 11:03, so I'll go quickly.
We actually are good on time, Onyema.
Oh,
So
are we good?
yes,
Oh,
take
good.
as long
Okay,
as you need.
okay.
Yeah.
It's still 11 or okay. I think it's important to understand, because of the implications for foster youth, their bodily autonomy or agency as it pertains to their reproductive and sexual health decisions, right? Reproductive justice, which recognizes the right to bodily autonomy, the right to have a child, the right to not have a child, and the right to parent your child or children with dignity and safe and sustainable environments, demands access to the full spectrum of reproductive health care and its technologies, right? This includes all contraceptive options, regardless of socioeconomic status, right? Or education level, or other situation. So, in short, yes, we want access to LARCs, or long-acting reversible contraceptives. But in the reproductive justice world, the question about LARCs is a nuanced and complex one. And Erica so eloquently and beautifully spoke about the dangers, right? And some of the concerns that in the reproductive justice world we have around this, the piece around it, there not being any shared decision making between patient and provider, right? It's a provider controlled sort of method in that, you need a provider to put, input, to sort of place the LARC, but also to remove it. And there are also cost barriers associated with it. And so, Erica beautifully noted that this leaves youth feeling disempowered around this. So, disempowered in the decision-making process. The RJ world is also concerned about historic uses of LARCs as tools for reproductive oppression and coercion, right? We have historically the US has a history of forced sterilization of folks that they deem unworthy of having children, right? When LARCs were introduced over 20 years ago, we saw efforts to tie welfare benefits to the use of LARCs, right? The idea being, caps on how many children people receiving welfare could have, right? And, using LARCs as a sort of incentive to access benefits that you need for family, to care for your family. We saw that we see that in certain cases. The ACLU years ago highlighted and sounded the alarm around folks who are punished by the criminal legal system in exchange for shortened sentences would be offered use of long-acting reversible contraceptives in exchange for reduced sentences. These are all these are all coercive tactics used to infringe on people's reproductive autonomy, right? And so, LARCs do pose a certain kind of risk in that you don't necessarily always have the control. And so RJ, the reproductive justice world, is really concerned about and attuned to and cognizant of the ways that a technology as wonderful as this, as efficacious, right, as LARCs, can be used as a tool for harm in a world where there are biases around who should be having children, who should be a parent, how one can parent, biases, which foster youth, right, are very much so within a population that society, right, has ideas around how, if, when, and how they should parent, right? And so while, yes, we want folks to have access to LARCs, we also want to be cognizant of the potential dangers that come with maybe heightened or targeted marketing of LARCs to young people, right? Because we recognize that young people, foster youth, are capable of making decisions for themselves in their own best interest, right? What they need is culturally competent or culturally congruent, medically accurate, comprehensive information to support them, in making the best decisions. Sorry, I got off my little my little what is it called? My script. But so these historic uses as tools for reproductive oppression and coercion, the need for providers to insert and remove LARCs, and the associated costs. There are costs around like childcare, if folks already have children, transportation costs, depending on whether or not it's covered by the kind of insurance you have, insurance to, the cost of inputting it and removing it, right? we see the data showing that LARC use among foster youth is relatively higher, right? And that's perfectly fine if in fact youth are able to make these decisions for themselves with all the information to support their decisions and without coercion due to biases around who should be having children or whether youth are capable of making decisions for themselves. I think it's interesting to note that the choice of contraceptive method is a personal decision, right? And it's highly contextual. Folks use contraception for different reasons, sure, for unplanned pregnancy. I mean, to keep from becoming pregnant, but also they might use contraception for endometriosis and fibroid or, other sort of reproductive health issues that might not be addressed by LARCs, but by other kinds of contraception. So if the assumption is, or if the focus on engaging with foster youth is we just don't want them to have children, or we want to mitigate issues around unplanned pregnancies, it means that we're not seeing them as a whole person and perhaps addressing other reproductive health issues that they might be seeking contraception for. So I think that's a thing we should think about. Like, we should think beyond mitigating unplanned pregnancies, right? Or unwanted pregnancies. We should also think about other reasons why folks might need and want access to contraceptives so that we can explore all the different kinds of contraception that is available to them and they can make that decision. We should treat adolescents as sort of partners in their decision making, and honor that they're capable of doing that. So we want to ensure that foster youth are offered dignified care that's unbiased, scientifically accurate, comprehensive, so that they can make the best decisions for themselves and their lives, because they're capable of doing so. And so when we think about LARCs, they're wonderful, fabulous, essential, right? An essential aspect of contraceptive care. And folks who want it should use it, but we should also in ensuring that it's accessible. I think reproductive justice also says that folks should have the decision to not use certain kind of contraception, and should be able to make those decisions without coercion. And so those, I think, are the nuanced thoughts. I got off my script, so I've lost my spot. But there's nuance in all of this, right? And these are things we should be thinking about, and dynamics we should be exploring when thinking about particular kinds of contraception and their availability to folks.
Thank you, Onyema. That was so beautifully said. And yeah, thank you for just talking to us a little bit more about how important the RJ lens is when it comes to looking at, all this data and all these numbers and the many things we need to think about. And like you said, it's very nuanced, and there's so much to think about as we kind of digest and dive into this data. And yeah, we want to make sure we're just honoring young people and respecting their bodily autonomy and remembering that they're capable of doing their thing, right? Making the decisions that are best for them. So thank you for sharing all of that. And thank you to all of our panelists. You all are so amazing. And we thank you for just adding so much life to this report, and also to our presenters. We are going to move on to our Q&A portion. Actually, I'm sorry. We're going to move on to a little bit around what's next, and then we'll move on to Q&A. So how can we ensure that youth are receiving the education and healthcare they require, right? There's so many things we need to think about. For example, what existing practices can be improved to better serve youth, what federal funding can be leveraged, and what policy changes are required at the local, state, and federal levels. So there's still a lot for us to think about and digest. And so, as we mentioned early on, or during the registration, you may have seen this is just really part one of a two-part webinar, and we're wanting to have part two in February, where we're going to explore more. Now that we've seen the data, what can we do, and what's next, and what do we have out there that we can leverage, or what do we need to work on together as a community? So please stay tuned for our next webinar, which we will send out notifications in the next couple of weeks or so for folks to register. But we'll move on to our Q&A portion of the conversation. I see that we have some questions, but they've been answered. So I want to invite, it looks like they all have been answered. So I want to invite folks to add in the chat any questions that may have come up. I think I see.
Cindy, the question that just came up in the chat is what is the RJ script or viewpoint? It's a definition question. So I think that may be for Onyema.
Yeah, thank you, Rebecca. Onyema, would you be open to sharing or answering this question?
Yes, yes. And so I'm definitely happy to. So reproductive justice is a framework that was, it's a term and a framework that was established by Black women, a group of Black women in the 90s. And it has 4 tenets. One, it's grounded in the human rights framework. It centers dignity for all persons. And it has 4 tenets. It says that everyone has the right to a personal bodily autonomy. Everyone has the right to have a child, the right to not have a child. And in the event that you do have a child or children, you're able to raise those children in safe and sustainable communities. Now, all of those tenets, or each of those tenets, contemplates something different, right? So the right to have a child, and I see someone's dropping the sister song definition in the chat. Thank you, Mariana, for that. Yes, that is the definition, and sister song is, one of the founders of the movement. The Honorable Loretta Ross was one of the co-founders of Sister Song. And so we do honor the Sister Song definition. And so within those 4 tenets of RJ, right, they contemplated a little bit something different about access to care. So the right to have a child can speak to access to it harkens back to the history of forced sterilizations of this country, right? Or in this country, of women of color, low-income people with disabilities. But it also speaks to maternal and infant mortality issues, right? Systemic issues that impact birth outcomes for our communities. So the right to not have a child speaks to access to abortion care, right? And the ability to determine whether or not to bring to carry a pregnancy to term. The right to sustainable environments, right, can be anything from your lived environment, whether you live within walking distance or within a certain radius of oil wells, right? Which has impact on the community's health in terms of, asthma rates, in terms of reproductive harms, actually, is what we're learning, whether or not you have access to green space, healthy, you live in a food desert, right? Or have access to healthy foods, whether you live in an environment or community that is plagued with gun violence and police brutality, right? All of that sort of is contemplated within the reproductive justice framework, and it all works to sort of fight reproductive oppression, and fights for an environment whereby we can have communities that support and facilitate our ability to determine our reproductive destinies, right? And it sort of demands that the government supports us in that, right? So it contemplates equity, justice, and the necessary supports that we need to sort of realize the vision of reproductive justice. I need a script always because I then start talking. But that's it. And happy to answer questions if folks have additional ones. And I'll drop my email in the chat in case folks want to connect too.
Onyema, I just wanted to add, if I may, just when you were talking about racism and discrimination, there was a study done after 9/11 that showed that Middle Eastern mothers had a spike in preterm labor following that event. And then we also saw that after incidents of police brutality, we see mothers of Black sons having higher rates of depression. So this data that we're looking at here was conducted in 2020, which May 25th was when George Floyd was killed. So it would be really interesting to see what the impact of that event was on the maternal and infant health for Black foster youth.
Yes, thank you so much for uplifting that, Catherine. I look forward to seeing. I agree, it would be interesting to see, because the impact of stress, right, the weathering effect on birthing outcomes for folks is a real thing, and we have to pay attention to that. So thank you for uplifting that, Catherine.
Thank you, Onyema. Thank you, Catherine, for that. We have a couple of other questions that have come in around SB 89. And Rebecca, I'm going to send this one to you, but if there's a better person, please let me know. The question is there any data showing rates of foster youth pregnancies before and after SB 89 and related regulations?
Yeah, that's a great question. So the Cal Youth studies, which we referenced before, do give us information about pregnancy rates before SB 89. And what we saw was, this was, again, the self-reported youth interviewed at ages 17, 19, 21. And at age 19, about half of the youth who identified as female had been pregnant at least once. So that's our best data about before SB 89. About 50% will have been pregnant by age 19, and by age 21, about a third will be parents. We also know that of those who became pregnant at by age 19, almost 2/3 said that this was not a planned pregnancy. Because Cal Youth is a private study that only happens sort of on that cycle, we don't have follow-up data. And that's one reason why this report and AB 172 is so important, because now annually we'll be having CDSS will be reporting out on the factors we see in this report, and we can work with CDSS to see if there's some other key factors we want to include. So we will be able to see some of whether there's been any impact and change in access to care since SB 89 has been implemented, and since all of the new policy and practice that CDSS has put out and that counties have been implementing. And I see there's also some questions about, are there any plans to expand training through SB 89 and mechanisms to measure whether that training is actually translating into more care from providers? So RHEP has been doing a biannual survey of youth in foster care. We just completed our 2023 survey. And in that survey, we ask questions of youth about whether their social workers have been talking to them about sexual and reproductive health, whether they've had access supporting whether they have had support accessing care, and whether they have been able to speak with providers, sort of the flip side of SB 89 in terms of youth. And we will be sharing out the findings from that 2023 study and comparing it to 2021 and 2019 very soon. But we are happy to say that preliminarily it looks like we are seeing some improvements, that SB 89 has made a difference. But that's to come. And who's in charge of providing SB 89 training? Alicia, I'm actually wondering if you want to speak to that, because that sort of goes back to what you were talking about, documentation.
Yeah, sure. Yeah, so towards the beginning, I had mentioned that the training can be done in person in a classroom setting and e-learning. So it's actually facilitated through the statewide California Child Welfare Training Learning Management system. So yeah.
All right, thank you all. Well, it looks like we answered all of the questions. Our next is just a thank you to all of you for joining us. We had a great group, so thank you all so much. Thank you again to our panelists, to our presenters. Please stay tuned. There's more to come. So this is just the very beginning. And yeah, please tell us what you think. You should have a survey pop up when you exit Zoom. So please help us improve our webinars and help inform the next one by telling us what you think. And yeah, thanks everyone. Have a great rest of your day.